السلام عليكم أعزائي طلبة وطالبات المرحلة الخامسة في كليه الطب جامعة تكريت. This is my third lecture about the congenital anomalies. We are now talking about urethral anomalies. We can see from the picture on the right side, we have the incomplete or bifid pelvis or bifid ureter and complete duplication. And we have on the picture on the left is an IVU picture showing complete urethral duplication. This is a common anomaly. It happens in about 1 to each 125 patients or live birth. And per se, it is not regarded as a serious anomaly unless it is associated with other anomalies like reflex, obstruction, and other, or etc. For duplication anomaly, we have what is called a Wiegert-Meyer rule. A Wiegert-Meyer rule, those two scientists, they discovered that in a duplicated, when there is in a duplicated system, complete duplication, when there is a urethrocoele, the ureter draining the upper pole usually ends downward and medial for the ureter draining the lower pole. So the ureter draining the upper pole downward and medial, and therefore they are prone for obstruction or urethrocoele formation. While the ureter draining the lower pole, it ends above and lateral, and they are prone for reflex disease. Mega ureter is a term used to describe the huge size of the ureter. As the picture on the right side above, we can see there is a huge size, huge enlargement of the ureter with dilatation and tortuosity of the ureter, and also a large size bladder also. And the picture on the left, we can see a dilatation and tortuosity of the ureter, male and particularly on the left side, and sometimes reaching an enormous size like that of the bowel, for example. And here the picture below, we can see after complete excision of the ureter, transection of the ureter, with here we can notice the pinpoint ending of the ureter, and then recreation of a normal caliber size of the ureter after doing tapering or tailoring of the ureter. We can do tapering by incision, by excision or complete transection of the ureter, or by plication. Application, just plicate the ureter down to the inside. These two procedures used to reduce the size of the ureter, and then reimplantation is done. An ectopic ureter is an example of ureter ending. The ureter normally ends at the trigone, at the area of the trigone, at the base of the bladder, while the ectopic ureter ends in a site other than its normal site. It differs for male and female, and the female usually ends below the true sphincter, and therefore the female usually presenting with continuous incontinence, dribbling of urine, with a pattern of filling of the bladder, with a normal pattern of voiding, while for the male usually ends above the true sphincter. It can end at the vas deferens or at the epididymis. So one of the main presentation of ectopic ureter is the current epididymitis in a young male. And for ectopic ureters, rarely the kidney is salvageable. I mean, the kidneys are usually non-functioning, except for sometimes rare presentations with ectopic ureter. Here, IVU picture on the left side. The kidneys is still functioning, but with the enlargement of the pelvis and calluses. And here we can see the redundancy of the ureter. An example also of lower ureteric anomalies is the urethrocoeles. These are circulation or dilatation of the lower end of the ureter. And here we can see from the picture on the right side, we can see either it could be an intravesical or ectopic. Intravesical, it means inside the bladder, or ectopic, it means outside the bladder. And it could be here the picture on the left side is the ultrasonic appearance of the urethrocoele, just like a cyst inside the bladder. And here the IVU picture below with the characteristic copper head appearance, on IVU. We have 4 types of secourethrocoele. It's a common anomaly in female more than male, in about 4 to 1. The secourethrocoele is one example of urethrocoele with ectopic presentation. Here the urethrocoele just crossing the bladder neck and reaching down to the external sphincter. We have what is called stenotic, sphincteric, sphincterostenotic, and sequourethrocoel. And this type, sequourethrocoel, acquires its name from the appearance or resemblance of the cecum. It looks just like the cecum. Here we have another examples. The picture of eye view picture on the right side. We can see the left kidney with the ending of the ureter with the copperhead appearance of the urethrocoel, and the left and the right side. We have the wall of the urethrocoel. It appears just like when there is a filling defect inside the bladder, and also there is a tortuosity and dilatation of the ureter with also enlargement of the pelvis and calyces. And the picture on the left side, we can see this is the cystoscopic appearance of the urethrocoel. For the management of urethrocoel, it differs. It could be either just puncturing of the urethrocoel, incision of the urethrocoel, a transurethral resection of the roof of the urethrocoel, like this picture and below. Or sometimes we are in need for just excise or transect the ureter and reimplant it, just like this picture on the right side. We excise the serosa and then the muscular layer or the detrusor muscle, split the detrusor muscle and deliver the mucosa of the bladder and suturing with the mucosa of the bowel, with the mucosa of the ureter, and then we buried this part of the ureter, covering it by the detrusor muscle outside and the serosa outside. So this is called the modified Leach-Krikor procedure. Can be done with the laparoscope or robotic surgery. And also the picture on the left, examples of the intravesical reimplantation of the ureter with a Cohen procedure or a Leadbetter-Politano procedure with a Paquin rule. The Paquin rule, it stated that the mucosal tunnel of the ureter should be with a 5:1 ratio. I mean the site or the length of the ureter should be just below the mucosa of the bladder in the length of 5:1 in comparison to the diameter of the ureter. This procedure is in need because of in children we are in need for anti-reflex measure, and this is the anti-reflex measure here with the Paquin rule. Another example of lower anomalies of the urinary tract, the ectopia vesicae or bladder exostrophy. Here we can see that there is a defect in the anterior abdominal wall, anterior bladder wall, and anterior urethral wall, and diversion of the symphysis pubis. The picture on the above right for the male and above left on the female, and this is a KUB picture. Also we can see a widely spaced symphysis pubis. It could be not just traumatic, it could be either also congenital, like in this case, ectopia vesicae. So what's important here in the bladder exostrophy, it's a quite rare anomaly. It's presented in about 1 for each 25,000 up to 1 in each 50,000 live births, and also associated with epispadias. Epispadias means the opening of the penis on the dorsum of the opening of the urethra on the dorsum of the penis, with or without incontinence. So what's important here in the bladder exostrophy is the management of the bladder exostrophy. It is a multi-stage approach for the management of bladder exostrophy. So at the first stage is done at the age of 3 days. We have to close the anterior urethral wall, anterior bladder wall, anterior abdominal wall, and with or without osteotomy, with reapproximation of the symphysis pubis. This is at the age of 3 days. Why this is important? Because this is important in order to enlarge the bladder, this template of a bladder. We have only just a small template of a bladder tissue, and we have to enlarge this side, this area of the bladder. Therefore, we close this template of a bladder to ensure urine resistance inside this closed segment in order to increase in size, because as you know, the bladder will not increase in size without the resistance of the urine. And for all those patients, they will develop a reflex disease. 100% they will develop reflex, and therefore and the second stage would be the epispadias repair at the age of 6 months to 1 year, and the third stage at the age of 4 to 5 years is the bladder neck reconstruction and anti-reflex surgery. A patent uricus is also another anomaly. Here the urine is dribbling coming from the umbilicus. We can see from the picture on the above on the right, and the drawing on the left, you can see there's a tract connecting between the bladder to the umbilicus. In surgery, here in laparoscopic approach, we can remove the umbilicus with the connecting stock with the bladder, and even a cuff of a bladder is removed. And this is important because this is a future site of tumor development, which is the adenocarcinoma of the bladder. We can, you know the types of bladder tumor. They have three types: the transitional cell carcinoma, squamous cell carcinoma, and adenocarcinoma. And in adenocarcinoma, we have, which represent about 2%, only 2% of bladder tumors. They are 1/3 of cases coming from inside the bladder, another 1/3 of cases coming from outside the bladder, from the patent uricus, and another 1/3 coming from tumors of the small or large bowel. For posterolateral valve is an example of anomaly of the urethral region, and here the valve here representing type 1 valve. We have type 2 and type 3, but when we are talking about posterolateral valve, we mean type 1. We usually mean type 1. The incidence is about 1 for each 5 to 8,000 live births, and the presentation is different. It could be mild, moderate, or severe according to the amount of urine presented during the amniotic cavity and the intrauterine development. So if the patient, for example, having a patent uricus may have a normal or good amniotic fluid containing. As you know, the amniotic fluid about 90% coming from the fetal urine. And if the patient or the mother having oligohydramnion, the child may develop also a lot of anomalies like orthopedic, CNS, or cardiovascular anomalies. Also, the proline substance presented in the fetal urine is very important for the future development of the lung maturity of the fetus. And therefore, some of those patients presented with RDS. So what's your job when you are working at the casualty? If you they bring a unit age more than 3 days and not passing urine, your rule is to pass a gentle passage, trial of a gentle passage of catheter, and you can see if the urine is coming or not. And also you can notice if the patient having RDS, for example, you should send him for investigation like blood urine nitrogen. If the creatinine is more than 1.2, this is a poor prognostic features. If you can notice also if the child is in need for an incubator or a ventilator, and etc. The definite management is with the cystoscopic appearance. Before that, I forget to mention that the procedure of choice for the detection of this valve is the posterolateral valve, is the voiding cystourethrogram. So we put a catheter inside the bladder. You can see how much the amount of urine is present in the bladder, and we can also inject a dye diluted with the fluid and remove the catheter and see if the child is urinating or not, and taking films, serial films for that. You can see here that there is dilatation of the area of the bladder neck and in the posterior urethra, and also indentation of the area of the bladder by thickening. It means that there is a thickening and the trabeculation of the area of the bladder. Here I forget also to mention that this kind of valve, the leaflets of valve, they are originated from the base of the prostate and reaching up to the bladder neck. So it prevents the antegrade movement or antegrade flow of urine, while it facilitates the passage of Foley, for example, if we want to pass Foley retrograde, passage of Foley. So it prevents the antegrade flow of urine, but it can facilitate the passage of a retrograde passage of a catheter. The definite management of this procedure is the diathermy of the procedure with a cystoscope and with incision of the bladder neck. But this is usually done at the age of 1 to 1.5 years of age. Until this age, we can do a cutaneous diversion, a temporary diversion. This is called vesicostomy. It means connection of the mucosa of the bladder to the skin, to the outside skin. This connection is temporary, and just under the diaper, and therefore it will make no difference to the child until the age of definite repair. Now, the hypospadias, it is a quite common anomaly facing us, the urologist. It happens in about one for each 300 live births, and having 3 different presentations usually, or 3 constellation, of presentations. There is a forward curvature of the penis, or chordee. There is excessive skin on the dorsum of the penis, and there is a ventral opening of the urethra on the penis. Therefore, the 3 presentations is regarded to as the hypospadias. Is there a hypospadias without? Is there a chordee without hypospadias? Yes, it could be presented, but here we are meaning or talking about hypospadias. It should be a forward curvature, bending forward, it means chordee, and a ventral opening of the urethra with excessive skin on the dorsum of the penis. The classification of the hypospadias here classified into anterior or distal, 50% of cases, which is the glandular, coronal, and subcoronal. And middle is the distal penile, midshaft, proximal penile, middle, representing about 30% of cases, and only 20% of cases proximal or posterior, which are the penoscrotal, scrotal, and perineal. Here, this classification is very important for the kind of procedure we use for repair of hypospadias. We have about 150 procedures for repair of hypospadias. It means that there is no single procedure fit for all cases of hypospadias. The selection of the procedure is depend on the location of the type of hypospadias. So this is an example of hypospadias with chordee, and here we should do degloving of the complete circumferential incision and of the skin and reaching to the base of the penis for release of the adhesion, and for sometimes we are in need for elliptical incisions on the dorsum of the penis and repair it with artificial erection. We can notice that the absence of the curvature. This is the procedure of the correction of the chordee, and this is called orthoplasty. A McBy is referred to as the meatal advancement and the glanduloplasty. It is the procedure here used by us for the cosmetic correction of the hypospadias hair type, glandular or coronal type. It is only just a manipulation of the glands for make it more cosmetic appearance of the hypospadias. It requires no urethroplasty or orthoplasty procedure. While this is the Snodgrass procedure or tubularized incised plate, in this procedure, this is for the cosmetic and functional correction of the deformity of the hypospadias. And we can summarize this procedure by making a midline incision in the middle from the tip of the old urethra to the end of the glans, and then relaxing midline incision. This incision is very important for release of the vascular endothelial derived growth factors, and these are very important to reduce the fibrosis and increase the healing of this procedure. And then the urethroplasty is completed, closure of the urethra for the creation of the new urethra, and then a second layer cover is taken from the prepuce, which is a prepucial flap, a second layer cover, or sometimes we take the flap from the adjacent dartos tissue. And then a third layer by the skin. A third layer cover is done by the skin. The flap is meaning the transportation of a part of tissue with its blood supply to another site with its blood supply. Here we can see examples of the rectangular flap from prepuce. A prepucial rectangular flap is taken and delivered anteriorly for treatment of a proximal hypospadias. And also this is another example of onlay flap, and the second layer covered by prepuce, also prepucial flap is covered, and after that a third layer of skin is also undertaken. Here the buccal graft, also an example of the management of the hypospadias. The graft, it meaning transportation of a part of tissue or piece of tissue without its blood supply into another site. And the process of take of the graft is called or re-establishment of the blood supply of the graft at the recipient site is called the process of take. So here, why the buccal graft? We prefer the buccal graft here because the buccal graft usually having a thick lamina propria, and this ensure a good or excellent process of take. You should also avoid here the injury to the stents and duct. The complications of hypospadias repair, we can note from the picture from A, here the presence of fistula formation, and the B is the complete hypospadias cripples. The complications could be meatal stenosis, fistula infection, diverticulum stricture, penile torsion, or procedure failure. The picture on B, complete failure of procedure, we should do complete excision of the procedure with also a buccal graft to the area, and then repair or repeat the procedure after 6 months. Now, thank you for your listening, and goodbye.